No, actually, it's just good. Not do anything with them. So, it's you can start. I want to send a video on this. Next time, what I'm supposed to do? Okay, that what it works. What is it? Disconnecting. Mm. Seringa. Yeah, like, got minimize. Person start here, no? Sorry. Yeah, no worries. So welcome back for the second session of epilepsy, pediatric epilepsy. And last time we have discussed into the historic perspective, basics of seizures, seizure classification, semiology. We have looked into various types, uh, the ILA definition of epilepsy. We've looked at various causes in different age groups, from neonatal to pediatric, even adult onset. What are the common etiologies we come across? Looked at drug-resistant epilepsy. How do you define epilepsy? And also the new classification of ILA system of the partial onset being replaced by focal onset generalized. We have looked into all these aspects, and the framework of the ILA is very important when you label diagnosis of epilepsy, and also the expanded version of the ILA definition and the seizure classification. And various phases of seizures also we have discussed, prodromal, aura, active phase. I won't go into the details. Again, we've also discussed about various aspects like how to differentiate between seizure and pseudo seizure. Martin, move on. Awesome. Uh, so welcome back. I think we have looked at the epilepsy, basics of seizures, classification, and semiology, and we're looking at the continuation of the session one. We have looked at the history of epilepsy, the sequencing history, precision medicine, the importance of ILA, various phases of epilepsy, how commonly we do misdiagnose epilepsy, what are the pitfalls of diagnosing a seizure in epilepsy, various modalities of EEG, video EEG being done, the definition of seizures and epilepsy, what is the difference between seizures and epilepsy, the ILA critical definition of epilepsy we have looked into, the various causes, that is from the neonatal age group to the pediatric and also adult onset. We have looked at the various etiologies, quickly looked at the drug-resistant epilepsy and also the new classification system of seizures, that what all we have newly coming up. I mean, we don't use the term partial, grand mal seizures, etc. We have looked into that in detail. And also the framework of epilepsy. It's very important that whenever we label a diagnosis, we need to look at all the directions. These are the various dimensions of epilepsy definition. That is the seizure type, epilepsy type, syndromic identification, comorbidities, and also the etiology. This is the expanded version of the seizure classification of ILA. We have looked into it, and we'll quickly go into. We have also looked into the definition of pseudo seizure. How do you differentiate between true seizure and a pseudo seizure, and syncope? What are the downfalls of overdiagnosing and underdiagnosing, etc. So we're coming properly into the seizure semiology. This session will look at various seizure semiologies and quickly followed by clinical videos. I think anybody's online, we can do an interaction as well. So the first session, the first picture here is depicting occipital seizures. So in the occipital seizure, I think we have discussed this before. We have various geometrical figures of colored objects. So on the left side, these are actually the pictures which are uh, which were drawn by the patient itself with occipital seizures. So we can have various colored, multicolored, various shapes, geometrical figures, and this needs to be differentiated with migraine aura. So remember, the headache is present in both occipital seizure and migraine aura. But in migraine, typically the headache lasts for a long time, and the aura will be a part of a small part of the headache, and it won't last for hours and hours together. But with occipital seizure, usually this visual hallucinations of these geometric figures will be a part of aura, and soon after that it will progress. It will have evolution. The seizure won't last like that for so many hours like that what you have in migraine. So here you have the onset as hallucination. Along with that, you may have vomiting, or sometimes you can have focal deviation of the face to one side. All that things can happen. Then sometimes you can have bilateral tonic-clonic seizure, unlike migraine. So, so it is quite confusing because headache is there in both migraine and occipital seizures. But these occipital seizures are obviously going to be episodic rather than migraine, because migraine can have a long-lasting clinical picture. And sometimes it can still be very confusing when you have clinical history alone. So you may have to get an EEG done. So EEG will obviously depict occipital spikes and discharges. So this is a quick slide on how to differentiate between occipital seizures and visual aura of a migraine. So not quite from the type of visions that multicolored, colored quantification. We have already discussed this. So based on the type of headache, sometimes you can differentiate, because migraine, the episode lasts for minutes to hours, but in the occipital seizure, usually it evolves within few seconds to minutes. And also remember, after the seizure stops, you can have a post-ictal headache in seizure. But in migraine, it's the opposite. I mean, during the The episode starts with headache, and sometimes you can have headache, vomiting, colored halos later on. With being unilateral and bilateral, it's very confusing because in children you can have bilateral as well. In adults, you have unilateral headache and migraine. And again, severity is again very subjective in children, can be mild to severe in both the conditions. But duration, as I mentioned, occipital seizure, no, seizures usually last with less duration, minutes with the max, half an hour. But migraine can last from 4 hours to 72 hours. The headache and the colored halos keep continuing. Along with that, you have photophobia, phonophobia, etc. So you may have to differentiate occipital seizures from migraine aura. So this is another phenomenon again concerning to occipital lobe seizures. So I think I have discussed this last time. What are the clinical situations wherein you suspect occipital seizures? The commonest one is a structural cause. For example, whenever somebody has occipital seizures, you may have to get an MRI done to look what is in the occipital cortex. Is there an ixon sitting there? Is there a neural cysticercosis or a tuberculoma sitting there? Or you have neonatal hypoglycemic brain injury causing gliosis, which is causing occipital seizures. And if the MRI is normal, you start thinking that no, it's not structural. Think of genetic causes. So in the genetic category, you have a few entities like early onset and late onset occipital lobe epilepsies. Early onset was previously called as Panetopoulos syndrome. The onset is usually between 2 to 6 years, whereas late onset occipital seizure is called the Gestart syndrome, that is between 6 to 10 years. So these are the two entities. Now the terminology has again been changed. The early onset occipital epilepsy, which was previously called Panetopoulos syndrome, is now termed as CELIAS. CELIAS is basically self-limited epilepsy with autonomic manifestations or autonomic seizures. The late onset occipital lobe epilepsy is called the COV, that is childhood onset occipital lobe seizures, occipital lobe epilepsy. So these are the two changes. I mean, these are the two conditions wherein you have occipital lobe seizures apart from the structural epilepsies. The commonest one is NHPI, that is neonatal hypoglycemic brain injury. So if you quickly in the same category of occipital lobe seizures, I mean, apart from the primary visual cortex, just beside the visual cortex, you have association cortex. It's called the visual association cortex. So whenever this area is involved, you have visual perception issues. Not only vision issues, but perception of vision can also go wrong. So you can have a varied type of presentations here. I mean, it is very difficult for a young child to describe all this, but an adolescent or maybe a late teenager, sometimes it's very well described in adults. So their vision perception, as itself says, there are various kinds of perception issues like, uh, agnosia is basically perception issues. So macrosomatoagnosia is macropsia is basically objects will look bigger. Micropsia is smaller looking objects. When your body looks bigger than normal, it's called macrosomatoagnosia. Somato basically means body. The body looks abnormally smaller, it's called microsomatoagnosia. And two more phenomena like telopsia and pilopsia. Telopsia is the farther objects looking near. Pilopsia is near objects looking farther. So, I mean, vice versa. So these are the various visual perception issues which can be seen. So there's one more entity called Alice in Wonderland syndrome. Sometimes you have body dysmorphia. Your body looks like this picture which is depicted on the left, the long neck and a long legs and a short body and trunk. This is called this is one of the picture which is depicted in Alice in Wonderland syndrome. And pretty rare, but it can be part of visual perception issues. So coming to the next type of seizure, sometimes auditory aura can be a part of a seizure. I mean, the seizure can begin with auditory aura. The commonest type of manifestation is basically the patient describes it as a buzzing noise. So this buzzing noise can be very disturbing sometimes, and typically they describe it is something different from tinnitus. Tinnitus is ringing in the ears. That is a manifestation of an inner ear disease. But if you have a buzzing noise before the onset of seizure, it indicates that you're probably uh, localizing it to an auditory cortex. So if you remember, what is the auditory cortex? The auditory cortex is a superior temporal gyrus. So if you see that the red part is called the Heschel's gyrus. This is one of the primary auditory cortex. So sometimes a focal cortical dysplasia or a structural cause sitting in the temporal lobe can cause buzzing noise as an aura, and then quickly followed by maybe tonic-clonic movements of focal seizures. Another type of aura is basically olfactory aura and gustatory aura. Remember, olfactory aura and gustatory aura, both of them come from the inferior frontal lobe, or it's called the piriform cortex. So sometimes the patients can have onset with abnormal sensation of smell, sometimes also abnormal taste like dysgeusia. You'll have metallic taste and metallic smell. So that's the commonest which is described. Sometimes the patient also describes this in the form of aura. So this is the piriform cortex, olfactory and the gustatory uh, centers. So also remember central hypothalamic control, that is central autonomic system, is basically being held in the hypothalamus and thalamic connections. So why is it so important? Because sometimes the temporal lobe is so closely associated with the thalamus and the hypothalamus. So whenever we have temporal lobe seizures, can have a rapid spread of that electrical impulse going to hypothalamus, and we can have autonomic manifestations or the connections between them. So medial temporal lobe has autonomic manifestations. So remember, whenever we have visual issues, it usually localizes to occipital lobe. Hearing issues, it localizes to temporal lobe. Always remember, autonomic manifestations will localize to the medial temporal lobe or temporal lobe epilepsy. So the autonomic manifestation in the form of a very vast symptoms like miosis, mydriasis, sweating, cyanosis, pallor, all these are in the form of autonomic manifestation. Sometimes you have hypotension, hypertension, bradycardia, tachycardia. So if you see even like conditions which affect thalamus and hypothalamus will cause a lot of autonomic fluctuations, especially in autoimmune encephalitis. We see autoimmune encephalitis has the limbic region which is involved. It's called limbic encephalitis because again it's closely connected to the hypothalamus and thalamus. And ANIC also because of the thalamic connections, thalamic tumors, head trauma, all these can be there. This is, I will have quickly about a lot of videos which are coming up. So just quickly see this video. So if you, I'll play this video again, closely observe and try to identify whether it's a seizure or not. First thing is it seizure or not? If not a seizure, why do you think it's not a seizure? So if you observe in this video, this child is completely conscious. He has some tonic posting, which is very weird in both upper limbs and lower limbs. And during the entire event, he's trying to answer. He's oriented to time, place, and person. He's telling in which, what is he currently studying. He's up to exam, so he's oriented to what he's talking about. So it could still be a focal seizure because sometimes awareness can be intact in focal seizure, but focal seizure will not have this type of semiology. This is definitely not a seizure. It's a paroxysmal non-epileptic event. So we don't use the term functional, we don't use the term malingering, we don't use the term other terms which are pseudo seizure like that. The terms which we use currently are the most accepted terminology across the globe. The first thing is first entity is called the FND, that is functional neurological disorder. It's an overall term wherein it's not an epilepsy, but it's just something abnormal. It's called FND, that is functional neurological disorder. Or the better term to use is basically PNE, that is paroxysmal non-epileptic event. So these are the two terms which are currently being agreed upon to use commonly, rather than the terms like old terms like functional, uh, pseudo seizure, malingering, etc. So another spotter for you. This child has come to you with history of seizures. This I just kept these two photos because examination is so important when you examine a child of epilepsy. Examination, general physical examination is so important. So what do you see on the left? If you see, this is a picture showing adenoma sebaceum. So where do you see adenoma sebaceum? Adenoma sebaceum is a very characteristic feature of tuberous sclerosis. On the right, this is a shagreen patch, typical location being the lower aspect of trunk, maybe in the lumbar region. So this is the leathery patch, like the podo orange type of appearance. It's called the shagreen patch. So both these neurocutaneous markers are very important in the case of epilepsy, especially in tuberous sclerosis and neurofibromatosis. So coming to the next video, try to understand and see what is the semiology of this particular patient. If you see, if you have noticed in this video, this child to begin with had a night seizure. So this you can see that's a video which is recorded in the night camera. A night seizure typically in a school-going child it started with sudden unresponsive episode when the child has a staring spell, and it's not that clear in this video, but this child had cyanosis, mydriasis, and also it was followed by vomiting, and he had some subtle facial twitching movements, hiccup-like movements. So, can you guess what type of epilepsy we are dealing with? Night seizures, vomiting, autonomic manifestation, mydriasis, cyanosis. So, this is typical Panetopolis syndrome, that is early onset occipital epilepsy, that is CELIAS. So, typically, Panetopolis syndrome starts between 2 to 8 years of age, wherein you have typical night seizures, which are very prolonged, unresponsive episodes, facial twitching, autonomic manifestations like mydriasis, meiosis, cyanosis, pala, followed by vomiting. And these are prolonged episodes, and the lifetime risk of having another episode is very less. In the lifetime, and this is one study which says that there's none. I mean, most of them do not have another episode, or around very less proportion of patients will have 1 or 2 episodes in their lifetime. So we may have to have a discussion with the parents on to need for discussion to whether to start or not to start anti-seizure medications. So this is a case of CELIAS or Panetopolis syndrome, wherein you have typical occipital plus the autonomic manifestations. So let's see another video. You see, this is a child, a school-going child with these episodes at night. Okay, I'll pause it here. If you see, this patient has a very violent type of facial twitching movements, right? So this hemifacial twitching movements, and it started in the initially on the right side, then it spread to the left. Then you have gurgling. If you put the audio on, this child has gurgling movements, gurgling sounds. Closely see, and then a lot of pulling of secretions also. CLORIA, and the typical facial twitching, and it's happening in sleep. So this type of semiology is very characteristic of an entity called Rolandic epilepsy. So it was previously called as Rolandic epilepsy, and now after that people started calling it BETS, that is benign epilepsy with centrotemporal spikes, and now the terminology has been reframed by ILA. It's called SELECT. SELECT is basically self-limited epilepsy with centrotemporal spikes. So in this, the characteristic semiology is going to be your facial, hemifacial movements starting on one side, going to the other side, then it can go to the upper limb, and sometimes the whole body can have bilateral tonic-clonic movements. You have facial twitching type of movements. You have numbness in the inner part of the buccal mucosa. You have excessive secretions and gurgling type of sounds. So all this is a typical semiology of BETS. So we're talking about, we had for the first seizure we saw was Panetopolis syndrome also happening at night. The second type of seizure, which is called Rolandic epilepsy, also happening at night. The third type of seizure also happening at night. Try to understand what is this type of seizure. So an adult patient, a female patient who wakes up suddenly at night, you see there is involuntary tonic posting of her left or one of her legs. And she's definitely not unconscious. She's surprised, and there's dystonic posting of left arm. But that's just very typical dystonic posting. And all these movements are very hyperkinetic or violent. So this is, as the name itself said, there's an entity called autosomal dominant nocturnal frontal lobe epilepsy. So I think the terminology has now been changed. It's called autosomal dominant hyperkinetic seizures. Um, Again, this is one of the oldest known epilepsies uh, with good 75% penetrance. It can have autosomal dominant inheritance, and exclusively the seizures happen at night. So the movements are very, very violent or hyperkinetic. That's why the name has been changed to hyperkinetic seizures. So the frontal lobe seizures are usually hyperkinetic, and they do happen in sleep, and they must be differentiated from other type of nocturnal epilepsies. One clue here is autosomal dominant frontal lobe epilepsy usually has a later onset, whereas Panetopolis has early onset. If you see the age, the earliest is Panetopolis, that in 2 to 6 years, BETS between 5 to 12 years, and autosomal dominant frontal lobe epilepsy usually between teenagers, and sometimes you can have an adult onset. So these are various type of sleep seizures. Also remember, sleep seizures must be differentiated from another entity called sleep-related night disorders. Okay. like somnambulism. So this entity is called parasomnias. So parasomnias are night events which happen. Sometimes they might be confused with sleep seizures. Okay, let's come to the next entity.
More and more children laughter can signal a heartbeat in capture. Giggling is such an endearing type of a giggle. Until we arrived in this giggle. It's just a talk. Something that's right. Potentially dangerous.
So this is one of the rarest form of seizures wherein the seizure presents itself as a laughter or an unusual smile or a grin. So the laughter which is described here is called laughter without the mirth. So that basically means that the child laughs without any reasons. It doesn't have the content that he's happy or something. He just laughs. And sometimes this laughter spells can actually be followed by bilateral tonic-clonic seizures. So this typical type of seizure is mentioned and described as gelastic epilepsy. So where do you localize gelastic epilepsy? Gelastic epilepsy usually most of the times, 80 to 90% of the times, you'll end up having a finding in the MRI which is called hypothalamic hamartoma. But the localization can be in the form of temporal lobe and also the frontal lobe, the inferior frontal lobe and the temporal lobe and the hypothalamic hamartoma. All these three involvement can cause gelastic seizures. So also remember, laughter can also be a seizure. And there's an equivalent of this entity, which is sometimes called as dacrystic seizures, wherein the child cries whenever he has a seizure. So that's called dacrystic seizures. He has tears. As the name itself suggests, dacrystic is basically the lacrimal gland. Let's look at a few more videos on the left. Try to identify whether it's a seizure or not first, and then if it's a seizure, what kind of seizure is it? So I put this picture because this child is completely aware. He's not lost his consciousness. He's maintaining his balance. He's looking at you, but he has left-sided twitching of movements of eyes and also his oral, perioral twitching movements. Very few twitching movements on the right eye as well. So, do you think this is a seizure? So, if you see very close differential diagnosis would be tics, but these are very focal clonic movements. So, this is a focal aware seizure. Awareness is intact. So, this child ended up having neurocystic psychosis. So, this child has left-sided focal seizure. So, we can localize it to the right motor cortex or motor strip. This child had right-sided neurocystic psychosis. Another video, the school-going child, these movements since last 2 weeks. So he has that breathless type of episodes. He gets anxiety, and immediately after that, he'll put normal saline nasal drops. After that, that event stops. So what kind of seizure gets aborted by normal saline nasal drops? There is no seizure like that. So obviously, this is a non-epileptic event. If you closely watch, yeah, so it's completely a non-epileptic event. You don't even have to get an EEG to rule out. Okay, another neonate. I think we have not seen any videos of neonate. Observe this is a 2-week-old neonate. Normal perinatal transition, normal family history. So is this a seizure or not? If at all seizure, what kind of seizure is it? So I think this is a very characteristic seizure. If you see this child, this baby has a tonic neck version to the right side. The baby is trying to turn the neck to the right side. And also some amount of head version, that is the neck in the head version. And also if you see, there is a focal onset seizure on the right side and then spreading to other side. You see tonic movements on the right hand, then right leg. And then if you see slowly, there's some amount of clonic movement spreading into the left hand and the left leg. So this can be described as bilateral, focal onset with bilateral tonic-clonic spread. But what is a better term to use? Basically, this is sequential seizure. The sequential seizure is starting at one arm and then slowly spreading elsewhere. It's called sequential seizure. Very a newly introduced term into the ILA terminology in the neonatal age group. So sequencing seizures usually indicate that there's a probable underlying genetic channelopathy. Commonest one is KCNQ2, but this child, we did whole exome sequencing and it turned out to be SCN2A mutation, pathogenic variant. So sometimes if you identify this seizure semiology, I mean, this child also had the similar pattern of EEG pattern, wherein the migrating seizures were noted. And we did this start this patient on phenytoin, responded very well to phenytoin. So remember, sodium channelopathies, especially sodium and KCNQ2 mutations, are in the neonatal age group gain of function mutation channel mutations because of that we can actually give sodium channel blockers. They respond very well to sodium channel blockers. In the contrary, Dravet syndrome and loss of function mutations, wherein we have to avoid sodium channel blockers, that usually has later onset after 3 months of age. So this child is basically a genetic channelopathy presenting as sequential seizures. Okay, try to identify what kind of seizure is it. Is it a seizure or not to start with? Yeah. So you can, I think typically you can see there is sudden head drop, and along with that, there's subtle shoulder movement as well. So this is a salam spell, typical salam spell. We don't use the term infantile spasms anymore. We use the term epileptic spasms because epileptic spasms can happen in neonates and also beyond infancy. So epileptic spasm is the newer term which is used by ILA. So this is a flexor spasm. Obviously, you have to go for an EEG, and also these are happening in clusters. The child has just woke up; he's sleepy as well. Okay, trying to identify what kind of seizure is this. I'll play again.
Okay.
Then he has a sudden head drop. Again, this is very close. When you have sudden head drop, you need to differentiate myoclonic seizure from an epileptic spasm. But this child did not have any shoulder movements, and this was a little faster than epileptic spasm. So this is a myoclonic head drop or a myoclonic seizure. So this child, again, we went ahead with MRI, and MRI was normal. We did in genetics, and genetics actually showed a gene which caused infantile early onset myoclonic epilepsy. Okay, let's see another type of seizure. This is a school-going child around 5 years with these kind of movements since last 1 month. Okay, so this is again very close. This is called the slow myoclonus. So this is little slower than myoclonus and little faster than epileptic spasm. So this is called the slow myoclonus. A very typical feature is whenever you have clustered or a time-logged myoclonic jerks. This is a feature of SSPE. Load out. So this is a feature of SSPE. Time-logged myoclonic jerks. So again, here the clue would be you would do an EEG, which shows generalized periodic epileptiform discharges, that is GPETs or radiomaker complexes. Just give me a minute. It's going to put in the loading. Go balance. Sir, continuous. So this is time log myoclonic jerks, what you see in SSP. So again, during the time, how do you see the duration of these episodes? Like, the fastest one is a myoclonic jerk, and then you have a clonic seizure, then you have epileptic spasm, and then slower than epileptic spasm is going to be a tonic seizure. Tonic seizure is going to be a little slow. So sudden jerk is myoclonic, then you have clonic seizure, then you have epileptic spasm and the tonic seizure. These are the durations of various seizures. Let's see a couple of videos more. 3-year-old child with these kind of sudden falls. So this is, if you know that this is an atonic seizure. So atonic seizures can also be a part of syndromes like LGS, and sometimes, it can be part of DOOS syndrome, also myoclonic astatic or atonic seizures along with the buckling of the lower limbs, that is DOOS syndrome. Let's see another video, just identify this is a type of seizure or not. So this child is admitted to us with the history of multiple seizures like this, and we have admitted this in the ICU. So this is a child with fires, that is febrile infection related epilepsy syndrome, and multiple focal seizures. This child is not responding during this episode. So this is a focal unaware seizure. So focal seizure because there's left twitching of the left hand, but along with the child is not responding, he has a blank staring look. So this is a focal seizure with loss of awareness. This was aborted by midazolam. Okay, let's see a few more videos. So do you think it's a seizure or not? If yes, what kind of seizure is this? I think everybody will agree because this is definitely seizure, because in this episode, the child has blank staring episode, motor arrest, and along with that, there's tonic posting of upper limbs. So this is a tonic seizure. Okay. The second video, a typical tonic-clonic seizure, because there's bilateral upper limb and lower limb involvement in tonic-clonic jerks, along with cry. So this is a tonic-clonic seizure. The third one, so this again is not responding during this episode. This is a focal unaware seizure. A typical facial type of twitching is seen in it's all the insular seizures, or it's a very typical feature of fires. Facial focal seizures, facial twitching, repeated episodes following a febrile infection, think of fires. Okay, coming to the next video. This child was another interesting kid who had episodes of this cough, paroxysmal cough like episodes since last couple of months. Very frequent, and the frequency has been increasing. Has been taken to multiple pediatricians. It was thought that it was GERD, Sandifer, abdominal colic. We even planned for barium studies and also 24 hours pH monitoring for GERD, and endoscopy, upper GI endoscopy was planned, thinking it was actually severe reflux. And all these episodes typically start, he wakes up in the night, he has this sort of cough-like episodes, and then it goes on for a long time. The child had not any have response for any PPIs and Lantus everything was done, nothing was conclusive. And before just the patient was took for barium studies. Clinical examination is so important. This child had an MRI which was being reported as encephalitis equally. If you see this is not encephalitis. If you closely see, though the picture is pixelated, that is hyperintensities on T2 and flare in various regions of the brain. These are actually cortical tumors. So now I think it was reported as meningeal encephalitis, but it's cortical tumors. So now you know the diagnosis. Then sometimes all that you need is basically just undress the patient and see the skin findings. Neurocutaneous markers are so important. This child was seen by many doctors, but none of them actually could find out that this child had neurocutaneous markers. These are typical ash leaf macules. Lanceolate shape, oval shape, hyperpigmented lesions, a telltale sign of tuberous sclerosis. So those were cortical tumors, and one of the cortical tumor was lying in the temporal lobe. So whenever this temporal lobe involvement, you can have something called ictal cough. So ictal cough is also a type of seizure. Sometimes temporal lobe involvement can cause ictal vomiting or ictal cough. Okay, coming to the next video. This is a 3-year-old child with these kind of episodes. And the EEG was abnormal. If you see this abnormal, very crossed abnormal EEG. This is also looking like salam spell. There's a sudden flexion of the neck and along with flexion of the upper limbs and happening in clusters. And he's confused. So this is epileptic spasms. Okay, coming to the next video, we quickly go. It's an adult epilepsy unit wherein this child was suspected, adult was suspected to have epilepsy. Then we wanted to know what kind of epilepsy is it exactly. So if you see this particular patient had the onset with right-sided head deviation. So whenever you're trying to identify, this is definitely seizure. Obviously, everybody would agree with it. Then the moment you identify it's a seizure or not, then you need to identify two things. One is localization and lateralization. Localization is basically you're localizing to which lobe. Is it frontal, temporal, parietal, or occipital? The second thing is lateralization, is right or left. So here, if you see that the patient has deviation of head towards the right side. Okay. So this is called the tonic head version. So head version to right has a very good low lateralizing sign. So that means there is some pathology in the left side. And head version is usually in the motor cortex. So there's some lesion in the left motor cortex. The cortex that's why he's having the right-sided deviation. And he has a violent kind of semiology. He has very violent movements and his vocalization. This could actually localize to frontal lobe because of these violent hyperkinetic movements. So this patient actually ended up having frontal lobe uh, FCD, focal cortical dysplasia. Another last one. This is a girl with multiple episodes of early morning myoclonic jerks and also these kind of movements. So if you see this girl has eyelid twitching like movements along with subtle uprolling of eyes. So this is another rare form of genetic generalized epilepsy. So what I could say is this is a very close cousin of JME. JME is in juvenile myoclonic epilepsy. So if you see these patients have myoclonic jerks, they can have generalized tonic-clonic seizures. EEG findings very similar to juvenile myoclonic epilepsy, but sometimes they can become drug refractory. Along with these movements, they also have something called eyelid myoclonia. So eyelid myoclonia is twitching lipo movements, commonly misdiagnosed as tics. But these eyelid myoclonic movements will have some subtle uprolling of eyes. And when you do an EEG, you'll have eyelid myoclonia like features. The polyspiking will be there in the perioccipital region. These patients also have something called eyelid closure sensitivity, eye closure sensitivity. So whenever they close their eye, they'll have a lot of polyspikes and spikes in the occipital region. So this is a typical syndrome which is mentioned as G1 syndrome. So G1 syndrome is basically a very close entity related to juvenile myoclonic epilepsy with eyelid myoclonia as a characteristic feature with other features which are diagnostic for that is eyelid eye closure sensitivity. All right. And with typically EEG findings. So this term has been now been replaced with a term called epilepsy with eyelid myoclonia. So it's called EEM with the eyelid terminology, epilepsy with eyelid myoclonia or G1 syndrome. Very often it's genetic. You can have a strong genetic predisposition, common in women, girls more than boys, same as juvenile myoclonic epilepsy. Sometimes they become drug refractory. You may have to consider other drugs for the control. And yeah, and this is one of the very closely related entity to juvenile myoclonic epilepsy. I think, yeah, we can end it here. Thank you. Stop sharing. Okay.
సార్ యాక్చువల్లీ ఏమైనా మీకు యూట్యూబ్ యాక్సెస్ లేదు మన నెట్వర్క్ బోర్డింగ్ నుంచి కనెక్ట్ చేయాల్సి వచ్చింది.
ఎందుకు మనం ప్రొసెస్ చేస్తాం?
జస్ట్